This is Rory Spiegel and Ryan Radecki, and this is the Annals of Emergency Medicine podcast, June 2024. Ryan, how you doing?
It's the shortest day of the year. It only goes up from here.
All right. It's only going to get better.
It's the darkest before the dawn, as they say.
All right. Well, why don't we hop in?
But the dawn, here it is. It's this beautiful, beautiful journal articles we're going to cover. In any event, the first article we're going to cover from the June 2024 issue is going to be called A Longitudinal Survey on Canadian Emergency Physician Burnout. Our lead author here is Kirsten DeWitt, and she is at the Queen's University, Kingston, Ontario, Canada. I know I'm not really sure there's a whole lot more that needs to be said than simply reading the author's conclusion. We found very high burnout levels in emergency physician respondents that have increased since 2020. So there you have it. They don't have it any better in Canada than they do in the United States or really anywhere else in the world. For what it's worth, these are the results of them applying the MASLAC Burnout Inventory Human Services Survey for medical personnel, a proprietary validated tool for measuring burnout. And it was conducted in approximately 380 docs in Canada out of about 600 originally invited at the beginning of the pandemic. As is fairly typical of these instruments, it reports scores reflecting emotional exhaustion and depersonalization, each of which increased between 2020 and 2022. Although it's unclear how meaningful the numerical change might be as a surrogate to either other physician wellness attributes or clinical care delivery effects. If you go online and read the entire article, you'll be treated to a smorgasbord of qualitative responses to the survey, and containing such gems as, I feel used and abused, powerless. And, this is awful, worst in 20 years, with no light, just darkness. Those wacky Canadians. Survey response bias notwithstanding, these results ought to be fairly concerning for the folks charged with operating the health system safety net up there in the Canadian provinces. But anecdotally, from what I see on my social networks, I suspect it has only gotten worse since this survey was conducted back at the end of 2022.
Yeah, I mean, I love the essence of emergency medicine, but this environment is drowning me slowly. I mean, this stuff is pretty awful. It's pretty impactful just reading some of these responses.
I mean, it's like going on Reddit and looking like our emergency medicine almost. It's like, hey, I'm a medical student thinking about going into emergency medicine. And it's like, don't do it. It's like, oh, wait, I love it. And then everybody piles on that person. But there's a survey response bias. I mean, the people who are going to be responding to this are going to be some of the ones with the bones to pick, not the people who are like chiming in to talk about how great their jobs are. They're too busy enjoying their lives. Like I said, a grain of salt. But, if you are somebody who's trying to retain and improve the effectiveness of the emergency medicine workforce in Canada, this article has to get your attention. You hope.
It does, certainly. And I think more so is like the reasons people are unhappy are so systemic, right? Like it's just like we have a broken system we're existing in. We are the safety net for that broken system. We've been given no resources. And we're offered doing a job that we're not supposed to be doing. And it's just like, how do you fix that?
Like encapsulates emergency medicine around the world. Right, like right there, you nailed it, Rory. Yes, resilience and online modules, Rory. Online resilience modules.
On your online modules, teaching us to be more resilient, right? Yes, that's often going to do it. And then, a 1 hour free yoga that you can do in the middle of your busy shit.
A coupon for DoorDash. Oh, okay.
That'll fix it.
Enough of that. Back to the good stuff.
All right, moving on. Our next article is the implementation of ultrasound-guided regional anesthesia program in the emergency department of a community teaching hospital. And the lead author is Robert Farrow. Ultrasound-guided regional anesthesia is something that is very much within the skill set of emergency clinicians. We have ultrasound and we have needles, and we're really good at both. But it's not often part of the repertoire to a wide degree. Sure, there's some of us do some dental blocks and digital blocks, but I don't think the majority of EM physicians are performing femoral nerve blocks, scaling blocks, so on and so forth. So these authors essentially report on the establishment of their program and the preliminary data after this rollout. It started in August 2020, where they implemented an ED-based ultrasound guided regional anesthesia program in their hospital system. It was a fairly extensive rollout, which basically included coordination with multiple departments, including orthopedics, anesthesia, pharmacy. They essentially got sign off from orthopedics on being able to do certain blocks with certain injuries. Pharmacy assisted in the development of the dosing guidelines and stocking the required anesthetics and lipid emulsion in the emergency department. And anesthesia assist was actually the training of regional nerve blocks to the emergency medicine faculty, ultrasound fellows, so on and so forth. And then the rest of the article just basically describes their experience. So essentially, from August 24th, 2020 to July 15th, 2022, 18 different clinicians performed over 229 ultrasound guided regional anesthesia procedures. The vast majority of the procedures were done by 3 advanced emergency medicine ultrasound fellowship trained attendings and 2 fellows. Overall, that was over 200 of the procedures were done by these 5 clinicians. The remainder were done by a few other clinicians, including a sports medicine attending, and then 4 other attending physicians and 9 other residents did a select few of these. The patients ranged from 14 to 99 years old. The median age was 51. I wonder who was doing a procedure on the 99-year-old, but I suppose a femoral nerve block from a hip fracture would be appropriate. Bupivacaine and lidocaine were the most typical medicines used in these procedures. Most of them seem to be effective. They report 2 patients did not actually get effective control of the symptoms. There were no cases of lidocaine or lidocaine toxicity. Overall, it seemed that the clinicians and the patients were generally happy with the procedures that were done and the training. The editorial by Adrian Malik does a really nice job kind of describing the barriers to prevent ultrasound guided regional anesthesia to be formed in the emergency department, sort of like what was described in the paper: training, logistical support, resistance from consulting services, et cetera. And the paper does go into the measures they incorporated in their rollout in overcoming these barriers. I think the big thing is, despite all this, despite having a very extensive training program, despite getting all these other services in to help, despite stocking the meds in the Pyxis, making sure you have the lipid immersion, all the stuff that would make regional anesthesia easy to do in the emergency department, the majority of these nerve blocks were only performed by a select few clinicians, who I imagine are the ones who were championing this project in the first place. You would have liked to see, after this whole endeavor, a broader number of clinicians actually participating in ultrasound guided regional anesthesia. To me, it seems like, for the most part, there are still barriers preventing the majority of clinicians from performing it.
Yeah, I mean, this is a 2-year period that they rolled this out and how to support. It is the COVID times, although it's Florida where COVID didn't happen or doesn't exist in any event. But yeah, their discussion in here leads off by saying, our work demonstrates it's feasible to implement ultrasound guided regional anesthesia in a community teaching hospital. It's really more like our work demonstrates it's feasible to allow 5 really passionate people to go off and do as many ultrasound blocks as they want. And a few people will tag along and pick up and do a few extra things, maybe because they have the stuff now. It's not really here's a bunch of people that we just upskilled in a new thing that they weren't comfortable with before, and now it's the standard of care at our hospital. We have 5 passionate clinicians who love ultrasound, and they did all these ultrasounds, and they didn't mess it up.
Right. I mean, technically, we have 3 passionate clinicians and some fellows who were doing it during their training. Unclear if they're still doing it now that their fellowship training is over.
Well, they were passionate enough to pursue this fellowship in any event.
Yeah, and there's nothing wrong with what they did. It's a very well done paper, at least in the description of what they did. It just speaks to there's still some significant boundaries to making this widespread.
Yeah, I mean, I love regional anesthesia in principle. There's a lot of responsibilities and different competing pressures in the emergency department and competing things that people have to get done during their shifts. And then it's hard to squeeze one more thing into a lot of people's, their routine and workflow. And they haven't quite demonstrated that, which I think would be a really powerful thing to see, that somebody's really rolled out a program that took root in their community hospital. The next article we're going to cover is called Topical Diclofenac versus Oral Ibuprofen versus Diclofenac with Ibuprofen for emergency department patients with acute low back pain. A randomized study. Our lead author here is Noman Kankel. and they are at Vassar Brothers Medical Center. So, this is yet another one of those have we yet found the miracle cure for low back pain types of articles? And even before hearing about it, you can probably assume it doesn't. Because finding that miracle cure would 100% win the Nobel Prize for medicine. And I'm pretty sure that hasn't happened. This study involves ibuprofen and diclofenac, and it involves rubbing the lotion on its skin, but there is no hose, nor is there a tiny dog or a pit. There are 3 arms to this trial: ibuprofen and placebo gel, placebo and diclofenac gel, and ibuprofen plus diclofenac gel. The first sort of yikes moment here, of course, is that the authors screened 3,281 patients in order to get 198 to randomize, trimming out primarily a whole host of chronic back pain patients, the elderly, the traumatic, and a bunch of other exclusions. Each of these 3 different groups lost about 3 to 6 patients in follow up, leaving about 60 in each cohort available for their 2-day post ED visit primary outcome measurement. It included patients tended male in their late 30s and were over 2/3 Hispanic Latino. The results had a wide distribution of pain symptoms in that immediate follow up period, ranging from none to severe, but there is at least one obvious winner: ibuprofen. The cohort was with the greatest Roland Morris Disability Questionnaire improvement at both 2 days and 7 days was actually ibuprofen plus placebo, while the least improvement was the diclofenac gel plus placebo. In the middle, exerting apparently inhibitory effect on ibuprofen, was the cohort in which both agents were used. So, a nice idea to try. Why not? But we see here no compelling reason demonstrated to add it to your practice.
Yeah, once again, ibuprofen seems to be the most effective agent we have.
And it's inhibited by diclofenac. The vagaries of small sample sizes. But yes, definitely nothing in here seems to favor the gel.
Yeah, all joking aside, Ryan likely means by inhibitory, it's probably just the randomness of
Yes,
having a small sample size.
very much.
And
Like I
probably
said, statistical chance. You rerun this many times, and it'll all reverse to the null.
probably the most likely outcome is diclofenac adds nothing to ibuprofen alone.
Yes. All right.
All right, moving on. Our next article is a dedicated outpatient pharmacy improves access to discharge medication in a pediatric emergency department, a quality improvement study. And I think the title says it all. The lead author is Jason Chu. So, a large portion of families don't pick up their prescriptions after ED visits. And not surprisingly, not picking up your prescription is a predictor for ED revisits. So, these authors were building a new pediatric emergency department, urgent care facility, and pharmacy, and took the opportunity to perform a quality improvement study designed to increase the rates of patients being discharged with their prescription in hand. In April in 2021, 7 months prior to the opening of the new ED and urgent care, a multidisciplinary team was formed, basically charged with improving the amount of patients that were discharged with a prescription. This team consisted of ED physicians, pharmacists, nurse practitioners, nurses, registration staff, so on and so forth. The authors note that most ED and urgent care encounters occur in the evening time. So by the time they're being discharged with their prescription, a lot of the pharmacies are closed. So they theorized that a major driver for improvement in patients actually getting their prescription would be a 24-hour access to an outpatient pharmacy. They did a ton of quality improvement interventions, essentially opening a 24-hour pharmacy, education of the registration staff, the providers, the nurses regarding the availability of the ED pharmacy and the 24-hour pharmacy, e-prescribing as the default in the EHR, ongoing analysis of medication usage and alterations in inventory as necessary, so on and so forth. They did a bunch of stuff. But when it all rolls out, it's fairly interesting what they found. Overall, there was over 23,000 patients discharged from the ED and urgent care over their period with at least one prescription. At baseline, 6.2% of the patients were discharged with medications in hand, and 46.7% had an e-prescription prescribed. After the opening of the ED pharmacy, there was a shift and a vast increase in the amount of patients who had medications who were discharged with medication in hand, up to 60%, and 94% of the patients were e-prescribed their prescription. So it's a fairly complex study, and they really go into all the quality improvements, things they did. But if you look at their charts, it's pretty clear the overwhelming benefit in the number of patients who discharged with prescription in hand came after the pharmacy, the 24-hour on-site pharmacy was open. That really seems to be the bulk of the intervention basically occurred after you had on-site pharmacy that was open 24 hours a day, who were capable of actually filling the prescription and bringing it to the patient at the bedside. This was the bulk of the improvement.
Yeah, I mean, I think this is there's a lot of face validity to the what they've shown here, in the fact that if you basically have prescriptions to give somebody, that's a pretty solid intervention. Or if it's easily accessible outside of regular business hours, or even co-located on the same site, that's going to greatly diminish the barriers to getting that prescription. They mentioned in the limitations that there's no way to link the receipt of these medications to improved patient outcomes based on the quality of our study. But like, in theory, you're providing these prescriptions to improve their outcomes in a medical sense, whether they're antibiotics or analgesia. And obviously, you can't design a study that tracks all those different patient-oriented outcomes for the diversity of different medications prescribed. But yeah, this is clearly good for patients, and they've measured that. This is a fantastic article in the sense that we should ideally. I know there's some like anti-competitive sort of like laws preventing you from being a pharmacy and a hospital at the same time sometimes. Ideally, this would be a fantastic thing to have available for patients everywhere in every possible venue, if such magic could happen.
It's so huge, right? You're discharging someone at midnight and there's no pharmacy open until 9 a.m. the next morning. It leaves these fairly large gaps. And it's like, I've spent 12 hours waiting in the emergency department, then being seen. I'm exhausted. I want to go home. The last thing I want to do is now spend another 4 hours trying to fill the prescription, so on and so forth. So having this on site is obviously huge. You're right. If we're just looking at, the rate of antibiotics filled for viral bronchitis, it probably won't make a difference. But overall, one would hope that the medications we're giving our patients should be beneficial and should prevent revisits to the emergency department.
Yeah, I know some rural facilities, and then you can also prove that there's no like capable pharmacies within 24-hour pharmacies within a certain radius, and you can actually dispense take-home packs of things to patients and things like that. Yeah, it's definitely the exception to the rule, especially in urban areas, where I'm pretty sure that it's challenging to get this sort of ability to give people their medications because of pre-existing restrictions on that sort of thing.
Right.
But,
even the idea that like you prescribe it, so by the time the patient gets discharged and walks to the pharmacy, the prescription is actually ready for them. I mean, that's also a fairly credible benefit.
Magical, amazing. The future is here. In theory, potentially, at least in Cincinnati, or was this in? Yeah, I think it's Cincinnati. All right, moving on to our final article here, a brief research report. The title is "Evaluation of Insurance Type as a Proxy for Socioeconomic Status in the Pediatric Emergency Department, a Pilot Study." The lead author here is Michael C. Munatu, and they are at the Boston Children's Hospital. This is, like I said, just a brief research report asking a fairly simple question. Can insurance status function as a sufficient proxy for socioeconomic status in emergency medicine research? This question is of interest because one of these bits of information is almost always readily available, insurance status, while things like parental education and family income are not. So these authors just simply did a pilot study of 300 patients to measure the concordance between public or private insurance type and high or low caregiver education or household income, with an annual income of $75,000 as their threshold for high or low. Suffice to say, I could break down the individual statistics for each type of misclassification, but it's rather more appropriate to just point you in the direction of the article online and to say the general gist of it is that you get about 20% wrong by doing so. If you're conducting the sort of research that allows your cohorts to be potentially misidentified by about 20%, then this surrogate will work for you. Otherwise, you'll have to put in the legwork to gather socioeconomic data from your participants in another fashion.
Yeah, not much more to add other than, it's more of like a research method study showing that this in and of itself is a poor surrogate. Now, it might identify its own form of bias, just like patients' insurance status, but as a surrogate for socioeconomic status, it doesn't work.
Which I think it's reported in demographic information a lot in studies. And I think people kind of read into it to some extent, like that it is some sort of a proxy. So this is actually kind of fairly useful for people who are interpreting the population demographics of different studies. When you look at the public insurance type, private insurance type, government payer, and so on and so forth. I think some people read into it in the back of their mind that it's correlated, and it sort of correlated, but there is obviously some misclassification.
Yeah. Useful study.
All right.
I think that wraps us up. As always, any comments, questions, or concerns, we can be reached at annalsaudio@acep.org. Otherwise, until next month, this was Rory Spiegel and Ryan Radecki, and this was the Annals of Emergency Medicine podcast.